This video has been put together to try to capture some of the essence of the Tameside and Glossop Primary Care Quality Scheme. The scheme was designed to see whether we could influence general practice culture to make it more conducive to continuous improvement. This would mean inspiring practices and their teams to really become a bit more aware of their own performance, to assess their improvement aims and then to try and meet these creatively. Shifting organisational culture is really difficult, and to do it we need to really inspire people at the grassroots. So let's hear some of their stories.
The Primary Care Quality Scheme came at a really good time for us because we were looking to just make general improvements to the practice.
It really helped us to focus on priorities for our patients, that's the important thing, and to review what we were doing and try and improve things.
It's been really helpful in enabling conversation and enabling dialogue, which means more people can get involved with more thinking.
I think it gives the team ownership, that's the important thing. So, you know, for everybody from receptionists to practice nurse, all the GPs here, they feel like they own the scheme.
The practice had been an outlier on several different areas, and using this scheme we were able to focus on these outliers and go from quite an embarrassing number of outliers of around 7 to reducing it to 1, nearly 0 outliers. So to then spread the news back to the staff that we have actually had a measurable improvement.
Every patient over the age of 60 has an invitation to get screened for bowel cancer every year. So I think it's every couple of years, and we were hitting about 50% of patients actually responding to that. So because it wasn't something we're in charge of, we thought, well, it's not really our problem. But of course it is really, because they're our patients. So what we've been doing is we've been writing to patients who don't do the test, and we've hit about 10% of those patients will then go on to do the test. So, you know, that's a big improvement.
One of the examples I'm going to give is with our COPD patients. Our prevalence was quite low, so we decided at a clinical meeting that if antibiotics were being given to a patient for a chesty cough, the clinician would read code that complaint as a chesty cough or a chest infection. This allowed me then to build a search that looked at people who'd had 1 or more lots of antibiotics in the last 12 months, who didn't have a diagnosis of COPD, who were either smokers or ex-smokers. These patients were then written to and invited in for full spirometry screening. As a result of that, our prevalence has gone up in the last year by 3.5%.
There are quite a few patient groups that have actually been involved with working with the practices.
PPG's been involved in several different ways, from things practical like helping with the redecoration of certain parts of the practice, being involved in discussions around the new patient screen that's been put into reception to improve patient feedback and patient communication.
We also involved our PPG and what their thoughts were, and it wasn't their suggestion, but it was through thoughts coming through by the PPG that inspired us to set up the food bank.
The potential for a PPG is as yet unfathomed. We've only really begun to scratch the surface.
As a patient of the practice, I think it's a really good idea, and I really enjoy being part of the PPG group. I think going forward, this whole project has got real potential.
Previous schemes have it's been a kind of one-size-fits-all, where you have to do exactly the same things as every other practice in your area, and the way geography goes, practices can't be the same in one particular area.
It's different we have this other scheme called QOF, which is still ongoing, but that's a national scheme. So it's helped us focus on the things that we really need to improve.
Each member of the team could be part of it. We distributed tasks to each of the team members, healthcare assistants, other doctors, nurses, receptionists, admin staff, so that everybody could play a role in implementing this scheme.
I think that the potential for this scheme is tremendous. I think that we can only see better relationships occurring within the team, within the practice, and with the patients as they learn to contribute better, and we all feel more comfortable together.
I've seen it as a way to continually improve. It's not just a means of getting our practice up on its feet, but actually to continue the good work that we've been doing.
Culture always trumps strategy, and and we forget this at our peril. Long-term effective change needs a grassroots approach with everyone pulling in the same direction. And if we believe this to be true, we must remember it with everything we do as a CCG. If we don't believe in the long-term effectiveness of top-down change, then we mustn't impose it. Instead, we must encourage, support, reward and celebrate the work of others. Taking this more complex approach is harder and it's much more difficult to measure, but the results could be remarkable.